If you've ever wondered how battlefield medicine evolved to save thousands of lives during the most catastrophic war in human history, you're in the right place. This channel dives deep into the untold stories of courage, innovation, and the razor-thin line between life and death on the front lines of World War II. Before we step into those operating tents where every second counted, hit that subscribe button and turn on notifications so you never miss a story that changed the course of medical history. Now, let's go back to a time when surgeons worked under canvas, with shells screaming overhead, and the distance between the battlefield and the operating table meant the difference between survival and oblivion. Picture a surgical tent somewhere in the Norman Bocage, July 1944. The canvas walls shudder with each detonation from the German 88s less than 2 miles away. Inside, under harsh Coleman lanterns that cast dancing shadows, a young American surgeon named Captain Robert Shaw stands over a table, his hands crimson to the wrists. The patient before him is a 19-year-old infantryman from Iowa, brought in 35 minutes ago with a shell fragment that tore through his abdomen. 35 minutes. Not 3 hours. Not 6. 35 minutes from the moment he was hit to the moment the scalpel made its first incision. That compression of time, that desperate shortening of the road from the point of wounding to the operating theater, is what this story is about. It's about how military medicine in World War II learned, often through bitter trial and bloody error, that moving surgery closer to the guns could transform mortality statistics and give thousands of young men a fighting chance they would never have had otherwise. Before the war, the accepted wisdom held that casualties should be evacuated as far back from the fighting as possible before definitive surgery. The experience of the First World War had shown the horrors of infected wounds, gangrene, and shock, but the solutions remained rooted in the old doctrine of long evacuation chains. A wounded man in 1918 might be carried by stretcher bearers to a regimental aid post, then by ambulance to an advanced dressing station, then further back to a casualty clearing station where some surgery might be attempted, and often all the way to a base hospital miles behind the lines before a surgeon would tackle the most serious abdominal or thoracic injuries. The reasoning seemed sound. Major surgery required sterile conditions, blood banks, X-ray equipment, and skilled teams, all of which existed only in well-established rear hospitals. But the cost of this caution was measured in lives. Men with penetrating abdominal wounds often died in shock during the long journey. Fractured femurs, without prompt stabilization, led to fat embolism and death. Internal hemorrhage claimed soldiers before they ever saw a surgeon's knife. The clock, it turned out, was as deadly an enemy as the shrapnel itself. World War II changed that calculus. The lessons began emerging in North Africa, in the scorching Tunisian desert of 1942 and 1943, where British and American medical officers started experimenting with what they called forward surgical units. These were small, mobile teams of surgeons, anesthetists, and nurses equipped with portable operating tables, sterilizers, and enough supplies to set up a functional theater in a matter of hours. The idea was radical for its time. Instead of waiting for the wounded to come back to you, you went forward to meet them. The U.S. Army deployed portable surgical hospitals and auxiliary surgical groups attached to division clearing stations, sometimes positioned just 2 or 3 miles behind the shifting front lines. The British organized field surgical units that could leapfrog forward as the battle moved, setting up in tents, commandeered farm buildings, or even the shells of bombed-out structures. The goal was singular and urgent: get the wounded man onto an operating table while he still had a chance, while his blood pressure hadn't bottomed out, while infection hadn't taken root, while the golden hour still glimmered. In the vastness of the Libyan desert, under canvas staked against the wind and the stinging sand, a British surgeon named Major James Collier worked through a night in November 1942. The Eighth Army was pushing Rommel's forces back after El Alamein, and the casualties were flooding in. Collier's field surgical unit had set up near a crossroads, close enough to the forward area that you could hear the 25-pounders hammering away at German positions. The wounded arrived caked in sand and blood, brought by ambulances that bounced over tracks carved into the desert floor. Collier's team worked in a rhythm born of desperate necessity. Rapid triage at the tent entrance, sorting the critically wounded who needed immediate surgery from those who could wait and those who were beyond help. A lance corporal with a sucking chest wound, his lung collapsed, was rushed inside. Collier's anesthetist, a soft-spoken captain from Edinburgh, placed an ether mask over the man's face, while a nurse cut away the tattered uniform. Collier opened the chest with swift, practiced strokes, clamped the intercostal artery that was pumping blood into the pleural space, and evacuated the clot. The lung re-expanded with a hiss. The soldier's blood pressure, which had been plummeting, stabilized. 30 minutes from arrival to surgery completed. 30 minutes that meant life instead of death. That same night, Collier operated on 14 men. 11 survived the initial surgery and were evacuated further back for convalescent care. Before the forward surgical unit had been established, before the doctrine of early intervention had been tested under fire, those survival numbers would have been reversed. What made this possible was not just courage or skill, though both were in abundance. It was a convergence of medical innovations and logistical rethinking that had been gathering momentum through the late 1930s and early war years. The discovery and mass production of sulfonamide drugs, the sulfonylamides that could be dusted directly into wounds or given orally to combat infection, was one piece of the puzzle. Another was the development of dried plasma, which could be reconstituted with sterile water and infused into a patient in shock, buying precious time before whole blood could be matched and transfused. Plasma had been pioneered by American researchers in the years before Pearl Harbor, and by 1942 it was being shipped to every theater of war in crates that could withstand the heat of the desert and the cold of the Russian steppe. The plasma saved lives in the first critical minutes and hours after wounding, when a man's cardiovascular system was teetering on the edge of collapse. It wasn't a perfect substitute for whole blood, which carried oxygen and clotting factors plasma lacked, but it expanded blood volume, raised blood pressure, and kept vital organs perfused long enough for a surgeon to stop the bleeding at its source. By 1944, whole blood was also reaching the forward areas in quantities that would have been unimaginable just 2 years earlier. Blood banks were established in rear echelons, with donations collected from soldiers on rest rotation, typed, stored in refrigerated units, and transported forward in insulated containers. In Normandy, after the June invasion, American surgical teams attached to evacuation hospitals and division clearing stations had access to fresh blood within hours of a casualty arriving. The impact was transformative. A soldier with massive hemorrhage from a torn femoral artery, a wound that would have been almost certainly fatal in 1918, could now be resuscitated with plasma, rushed to surgery, have the vessel ligated or repaired, and receive transfusions of whole blood to replace what he'd lost. The statistics bore out the revolution. In the First World War, abdominal wounds carried a mortality rate of around 30 to 40% even among those who reached surgical care. In World War II, with forward surgery and blood replacement, that rate dropped to below 15% in many units. For chest wounds, the improvement was even more dramatic. The difference wasn't magic, it was minutes in medicine. Then there was penicillin. The story of penicillin is one of the iconic medical narratives of the war, but its arrival on the battlefield was gradual and uneven. Alexander Fleming had discovered the antibacterial properties of the penicillium mold in 1928, but it took more than a decade of painstaking work by Howard Florey, Ernst Boris Chain, and their colleagues at Oxford to turn that discovery into a drug that could be mass-produced and used clinically. By 1943, penicillin was being manufactured in the United States in quantities sufficient to treat Allied troops, but it was still scarce and jealously rationed. The first large-scale battlefield use came in North Africa and Italy, where American and British medical officers discovered that penicillin, injected intramuscularly every few hours, could halt the progression of wound infections that would otherwise have led to septicemia and death. By the time of the Normandy invasion in June 1944, penicillin was being stockpiled for the expected flood of casualties. Surgeons in forward surgical units were instructed to administer penicillin as soon as possible after wounding, even before surgery, and to continue it post-operatively. The results were astonishing. Gas gangrene, the nightmare infection caused by Clostridium bacteria that had claimed thousands of limbs and lives in previous wars, became far less common. Streptococcal and staphylococcal infections, which had turned even minor wounds into killers, were now treatable. Penicillin didn't eliminate infection, but it turned what had been a death sentence into a manageable complication. And because forward surgical units could administer penicillin immediately, they closed yet another window through which death had previously slipped. The surgical techniques themselves were also evolving. Surgeons learned that aggressive debridement, the cutting away of all devitalized and contaminated tissue, was essential to preventing infection. They learned that primary closure of wounds, stitching them shut immediately, was often a mistake. The doctrine became debride thoroughly, leave the wound open, pack it lightly, and plan for delayed primary closure once infection risk had passed. This was messy, unglamorous work, but it saved limbs and lives. For fractures, especially the devastating femur fractures caused by high-velocity projectiles, the Thomas splint became standard equipment. Developed in the First World War, the Thomas splint immobilized the thigh and applied traction, preventing the jagged bone ends from tearing through muscle and blood vessels during evacuation. Mortality from femur fractures in World War I had been horrific. In World War II, with prompt splinting and forward surgery to control bleeding and debride wounds, the survival rate soared. Forward surgical teams carried Thomas splints, plaster, and the knowledge to use them. But let's not romanticize the conditions. These surgical units operated under circumstances that would horrify any modern surgical team. Sterilization was a constant challenge. Instruments were boiled in portable autoclaves or sterilizers heated by gasoline burners. Gloves were reused, washed, and re-sterilized until they fell apart. Surgical gowns were rinsed in disinfectant and hung to dry. In the desert, sand infiltrated everything. In Italy's mountains, it was mud and cold. In the Pacific Islands, humidity turned the air into a soup where mold grew on sutures and flies swarmed the moment the tent flaps were opened. Anesthesia was delivered with methods that today seem almost medieval. Ether dripped onto gauze masks, chloroform in emergencies despite its cardiac risks, and later sodium pentothal for rapid induction when the anesthetist had the time and supplies for intravenous access. There was no such thing as a ventilator. If a patient stopped breathing, the anesthetist bagged him by hand. Monitoring was by feel and observation, pulse, skin color, pupil response. The surgeon and anesthetist communicated in terse shorthand across the operating table, each trusting the other's judgment implicitly because there was no alternative. And always, there was the war. The Germans shelled Allied forward surgical positions in Italy with methodical precision. In the Battle of Monte Cassino in early 1944, a British field surgical unit operating in a stone farmhouse 2 miles behind the line took a direct hit from an artillery round. The building collapsed, killing 2 nurses and a surgeon, and destroying most of their equipment. The survivors dug through the rubble, salvaged what they could, and were operating again within 12 hours, this time in tents pitched in an olive grove. On the Eastern Front, Soviet forward surgical detachments operated under conditions that defied description. German bombardments were relentless. Supplies were scarce to the point of desperation. Soviet surgeons sometimes operated without gloves, using alcohol or iodine to disinfect their hands, because there were no gloves to be had. They reused sutures pulled from the bodies of the dead. They worked by candlelight when generators failed, yet they saved thousands of lives, often performing amputations and damage control surgery that allowed wounded soldiers to survive long enough to be evacuated by rail or truck to rear hospitals. The Soviet doctrine of forward surgery was born of necessity and ideology. Every soldier was precious, and the state demanded that everything possible be done to return him to the fight, or at least to save his life. In the Pacific, the challenges were different but no less brutal. The jungle islands of Guadalcanal, New Guinea, Saipan, and Okinawa presented a toxic combination of heat, humidity, disease, and an enemy that fought with fanatical determination. American forward surgical units, often called portable surgical hospitals in the Pacific Theater, set up on beachheads still under sporadic fire, in jungle clearings hacked out by engineers, and aboard hospital ships anchored offshore. The casualties arrived soaked in sweat and rain, their wounds already crawling with maggots if the evacuation had taken more than a few hours. Malaria, dengue fever, and dysentery were endemic, complicating the care of trauma patients whose immune systems were already compromised. A lieutenant named Sarah Mitchell, a surgical nurse from Oregon, kept a diary of her time on Okinawa in the spring of 1945. She wrote of operating in a tent where the temperature reached 110 degrees Fahrenheit, where the roof leaked during the torrential rains, and where the nearby artillery was so loud that the surgeon had to shout his requests for instruments. She wrote of a 19-year-old Marine brought in with his intestines spilling from a bayonet wound, of holding his hand while the surgeon worked, of whispering reassurances she wasn't sure he could hear. The boy survived, evacuated to a hospital ship, and then to Hawaii. Mitchell wrote that she cried for the first time in 6 months after that surgery, not from sadness, but from relief that something, anything, had gone right. Triage was the gatekeeper of survival, and it was the most agonizing responsibility in the forward surgical unit. When casualties arrived in waves, sometimes dozens in a single hour after a major assault or artillery barrage, the medical officer at the entrance to the surgical tent had to make life-and-death decisions in seconds. Triage categories were ruthlessly pragmatic: immediate, delayed, minimal, and expectant. Immediate meant the patient needed surgery right now, or he would die within the hour. Delayed meant he was seriously wounded but stable enough to wait. Minimal meant walking wounded who could be patched and sent back or evacuated without surgery. Expectant was the cruelest category. It meant the patient was so gravely injured that he would likely die even with surgery, and in a mass casualty situation, the limited surgical resources had to be devoted to those with a better chance. Expectant patients were given morphine, made as comfortable as possible, and a chaplain or nurse would sit with them if time allowed. Surgeons hated the expectant category, but they understood the arithmetic. If you spent 2 hours trying to save one man, who probably wouldn't make it, 3 other men who could have been saved might die waiting. It was the coldest form of utilitarianism, and it haunted the men and women who had to make those calls. Captain Shaw, the surgeon from Iowa we met in that Norman tent, would later describe triage as the thing that aged him more than any other aspect of the war. He said he could still see the faces of the men he'd marked expectant, decades after the war ended. But for those triaged as immediate, the forward surgical unit was a lifeline. Take the case of a German soldier, a young conscript named Klaus Weber, wounded in the Falaise pocket in August 1944. Weber was hit by shrapnel from an Allied fighter-bomber attack, the fragments tearing into his abdomen and thigh. By the time Canadian stretcher-bearers found him among the wreckage of his unit's retreat, he'd been lying in a ditch for 4 hours, semi-conscious from blood loss. He was evacuated to a Canadian forward surgical unit operating in a requisitioned barn near the village of Trun. The Canadian surgeon, a major named Leclerc, later recalled that Weber was in profound shock, his blood pressure barely palpable, his skin cold and clammy. They started plasma immediately, 2 units, while Leclerc scrubbed and the anesthetist intubated Weber with a rubber tube and began dripping ether. Leclerc opened the abdomen and found a perforated colon and a lacerated spleen. He removed the spleen, resected the damaged section of colon and brought out a colostomy, ligated bleeders, and packed the abdomen. The surgery took 90 minutes. Weber was transfused with 3 units of whole blood during and after the procedure. He survived, was held as a prisoner of war, and eventually returned to Germany. Leclerc wrote in his report that Weber would certainly have died if he'd been evacuated to a rear hospital before surgery. The forward surgical unit, operating just 3 miles behind the advancing Canadian front, had saved an enemy soldier's life not out of sentiment, but because the surgical doctrine didn't discriminate. A wounded man was a wounded man, and if you could save him, you did. The Battle of the Bulge in December 1944 and January 1945 tested the forward surgical doctrine under the worst possible conditions: winter in the Ardennes, snow, freezing temperatures, and a massive German offensive that caught the Allies off guard. Forward surgical units found themselves not just near the front, but sometimes in danger of being overrun. One American portable surgical hospital, attached to an evacuation hospital near Bastogne, continued operating even as German forces encircled the town. The surgeons and nurses worked in a stone schoolhouse, with blankets hung over the windows to maintain blackout, and a single pot-bellied stove barely keeping the temperature above freezing. Wounded men arrived with frostbite in addition to their combat wounds. Plasma froze in the cans and had to be thawed over the stove. Blood transfusions were started with the bottles tucked under the patient's armpits or against the surgeon's body to keep them from freezing. The surgical team operated continuously for 72 hours during the height of the siege, powered by coffee, cigarettes, and adrenaline. When Patton's Third Army broke through and relieved Bastogne, the surgical unit evacuated more than 200 wounded men who had been stabilized and prepared for transport. The survival rate among those who reached the forward surgical unit was over 90%, a statistic that would have been unthinkable in any previous war fought under such conditions. Anesthesia in the forward surgical setting deserves a story of its own. The anesthetists, often young doctors, with minimal training in anesthesia before the war, learned their craft under fire and became extraordinarily skilled at keeping patients alive on the table with limited resources. Ether was the workhorse anesthetic, despite its flammability and the risk of explosion when used near electrical equipment or open flames. Chloroform was faster acting but could cause fatal cardiac arrhythmias, so it was reserved for emergencies or when ether wasn't available. Spinal anesthesia with procaine or its derivatives was used for lower body surgery when the patient was stable enough and the anesthetist had the skill to perform the delicate injection into the subarachnoid space. By 1944, sodium pentothal, a short-acting barbiturate, was becoming available for intravenous induction, allowing a smooth, rapid transition from consciousness to unconsciousness before switching to ether for maintenance. But intravenous anesthesia required intact veins for access and time to set up, luxuries not always available in a forward surgical unit with patients arriving in hemorrhagic shock. The anesthetist's skill lay in improvisation and judgment. When to push fluids, when to hold back to avoid overloading damaged lungs, when to lighten the anesthetic because blood pressure was dropping, when to deepen it because the patient was moving. They monitored pulse by finger on the carotid or radial artery, watching the patient's color and breathing, communicating constantly with the surgeon. If the patient arrested, the anesthetist performed cardiac massage by hand, compressing the chest or even reaching into the open chest if it was a thoracic case, while the surgeon called for adrenaline and calcium and everyone prayed. The logistics of keeping a forward surgical unit supplied were a feat of military organization. Each unit required a constant flow of sterile instruments, sutures, dressings, plasma, whole blood, anesthetics, penicillin, sulfonamides, morphine, intravenous fluids, surgical drapes, gloves, soap, disinfectants, and the myriad other consumables that modern surgery demands. In North Africa and Italy, supply was by truck convoy, often under air attack or delayed by blown bridges and mined roads. In the Pacific, it was by landing craft and sometimes by airdrop. In the Soviet Union, it was by rail when the rails weren't destroyed, and by horse-drawn wagon when they were. Quartermasters performed miracles, but there were always shortages. Surgeons learned to do with less, to substitute, to sterilize and reuse what in peacetime would have been discarded. They learned to operate without X-rays when the portable X-ray machine broke down or couldn't be brought forward. They learned to feel for shrapnel fragments with their fingers, to gauge the depth of a wound by its appearance and the patient's symptoms, to make decisions based on clinical judgment honed by relentless repetition. The human cost of this work, the psychological and emotional toll on the surgeons, nurses, anesthetists, and enlisted medics who staffed the forward surgical units, was immense. They worked shifts that lasted until every patient had been seen, which could mean 20 or 30 hours without rest. They operated on friends, on men from their own units, on boys who reminded them of younger brothers. They made mistakes, because everyone makes mistakes under those conditions, and they lived with the knowledge that a mistake in a forward surgical unit often meant death. They saw things that would haunt them for the rest of their lives. The young soldier whose face had been obliterated by a mine, the tanker burned beyond recognition, the paratrooper whose abdomen had been opened by a tree branch during a drop, and who arrived with his intestines cradled in his own hands. They also saw remarkable resilience, the human body's capacity to survive trauma that should have been fatal, the will to live that kept a man's heart beating long after medical science said it should have stopped. They formed bonds with their colleagues that went deeper than friendship, the kind of bond forged by shared suffering and shared purpose. And they carried guilt, survivor's guilt, for the ones they couldn't save, for the soldiers they'd marked expectant, for the choices they'd made under impossible circumstances. There were small victories that mattered as much as the statistics. A nurse named Lieutenant Helen Kowalski, working with an American auxiliary surgical group in France in the autumn of 1944, remembered a particular patient, a sergeant from Texas who'd taken shrapnel to the liver. The wound was massive, and Kowalski didn't think he'd survive the surgery. But the surgeon, a captain named Friedman, was meticulous and lucky. He packed the liver, controlled the bleeding, and closed the abdomen. The sergeant received 6 units of blood. He went into shock twice post-operatively, and each time the team pulled him back. After 3 days, he was stable enough to evacuate. Kowalski heard later that he'd made it to England, to a general hospital, and eventually back to the States. She never learned his name, didn't remember his face after so many others, but she remembered the feeling of triumph when his blood pressure stabilized that second time, the sense that maybe, just maybe, they were making a difference. Not all theaters had the same resources. The Eastern Front was a place of extremes, where the sheer scale of the carnage dwarfed anything seen in the West. Soviet forward surgical units, sometimes called field hospitals or forward surgical detachments, operated under a constant influx of wounded that could reach thousands per day during major offensives. Soviet surgeons developed techniques for rapid damage control surgery. Stop the bleeding, remove the most obvious foreign bodies, close or pack the wound, administer whatever antibiotics were available, and move the patient out to make room for the next. They couldn't do definitive reconstructive surgery. There was no time, no resources, but they saved lives by the tens of thousands through sheer volume and determination. German surgeons, as the Wehrmacht retreated and supply lines collapsed, faced their own desperate struggles. The Hauptverbandsplatz, the main dressing station, and the Bürgerliche Kriegslazarett, the mobile field hospitals, tried to maintain the standards of forward surgery even as the Reich crumbled. By 1945, German medical units were operating without penicillin, without adequate plasma, often without anesthetics beyond local infiltration with procaine. They did what they could with sulfonamides and prayer, and still they saved some. The legacy of World War II forward surgery echoes through every modern trauma system. The concept of the golden hour, the idea that rapid intervention in the first 60 minutes after injury dramatically improves outcomes, was born in the surgical tents of Normandy and the Pacific. The trauma protocols we use today, the emphasis on stopping hemorrhage, resuscitating with fluids and blood products, early antibiotic administration, and damage control surgery, all have their roots in the lessons learned under fire. The civilian trauma centers that now operate in every major city, the helicopter medevac systems that can have a critically injured person in an operating room within minutes, the blood banks that stand ready around the clock. These are the descendants of the forward surgical units that proved you could bring definitive care to the point of injury and change the outcome. The military medical services of the world still organize around the principle that shorter evacuation times and forward surgical capability save lives. MASH units in Korea, forward surgical teams in Vietnam, combat support hospitals in Iraq and Afghanistan, all owe their existence to the doctrine tested and proven in World War II. But perhaps the most enduring legacy is the human one. The surgeons and nurses who staffed those forward units went on to become leaders in civilian medicine, bringing the lessons of trauma surgery to emergency rooms and teaching hospitals. They trained the next generation, passing on not just techniques, but the ethos of doing everything possible, with whatever you have, for the patient in front of you. They demonstrated that medicine under the worst conditions is still medicine, that compassion and skill can coexist with exhaustion and fear, and that the fundamental mission to preserve life doesn't change, whether you're in a pristine operating theater or a tent shaking with the concussion of artillery. The wounded soldiers who survived because a forward surgical unit got to them in time went home, rebuilt their lives, and in many cases never knew how close they'd come to being another name on a casualty list. They lived because someone decided that the road to the theater needed to be shorter, that surgery needed to move forward, that minutes mattered more than safety or comfort or convention. So when we look back at World War II, when we tally the dead and assess the strategies and debate the turning points, Let's also remember the surgical tents, the farmhouses, the bombed-out buildings, and swaying hospital ships where a different kind of battle was fought. It was a battle against shock and hemorrhage and infection, against time and entropy and the indifference of metal fragments tearing through flesh. It was fought by men and women who signed up to heal, who found themselves on the edge of combat, who discovered reserves of courage and skill they didn't know they possessed. They shortened the road to the theater, and in doing so, they lifted the survival odds for hundreds of thousands of wounded soldiers who otherwise would have died. Their story deserves to be told, not just because it's a chapter of medical history, but because it's a testament to what human beings can accomplish when they refuse to accept that death is inevitable, when they push back against the darkness with scalpels and sutures and a stubborn insistence that life is worth fighting for. If this story moved you, if you learned something about the ingenuity and compassion that defined battlefield medicine in World War II, then I hope you'll join this community. We're dedicated to bringing you these deep dives into history's most compelling moments, the stories of ordinary people in extraordinary circumstances, the innovations that changed the world, and the sacrifices that made them possible. Hit that subscribe button, ring the notification bell, and let's keep exploring history together. There's so many more stories to tell, so many more voices from the past that deserve to be heard. Thank you for watching, and I'll see you in the next one.